गुड मॉर्निंग एवरीबॉडी. आप लोग भी ध्यान से सुनो जो पीछे ये बैठे हैं. Anyway, it is. So I'm very sorry that we have a very sparse audience because it's last day and squint even otherwise is. Anyway, so this instruction course basically is aimed on targeting the audience which is basically to understand the basics of squint first, because until and unless you don't have understand the basics of squint, you cannot go further. That is all very important, because you see in most of the medical colleges, I'm very sorry to say, including my medical college when I was there, nobody taught strabismus. Nobody taught strabismus, nobody was doing strabismus, they were all referring patients. So last year also we had done an instruction course on basics of strabismus. Now this is almost the same, but we're trying to change a little bit. Well, we classify strabismus as, we will go step by step so that you can understand those people who are doing or starting strabismus. Pseudo-strabismus. That is one of the very important aspect you must distinguish from actual strabismus. Latent strabismus are phorias, manifest strabismus are known as tropias, concomitant. Then in the manifest you have concomitant and non-concomitant. Non-concomitant or incomitant may be paralytic or restrictive. So this is what basically you have to start, because there are a lot of patients who are referred saying that the patient has strabismus. But you have to distinguish between what is an actual strabismus and what is a pseudo-strabismus. Mongoloid features are there, and in those patients, because of the prominent epicanthus inversus, or even the normal epicanthus if you have, or a telecanthus if you have, in those patients the eye would look to be esotropic. The best and the most simple way to differentiate between an actual strabismus and a pseudostrabismus to do a cover-uncover test. See, it is a very simple test, and if you find the movement, then there is a strabismus. If you don't find any movement, it is not a strabismus. So cover, uncover and alternate cover, these are so important basic tests which if you do properly, half of your problem will go. Now, how, when a patient comes to you or he has been referred to you, you have to differentiate, as I told you before, whether there is a strabismus or there is no strabismus, or if there is a tropia or phoria. These two things are very important, because the treatment of phorias is different, the treatment of tropia is different. So actually, I would go further on this. We have the cover test. First is the cover test. Now cover test means you cover one eye and remove and see, you keep it covered. You just cover one eye. Suppose you cover the right eye. You cover the right eye and see the movement in the left eye. This is a simple cover test. If there is a tropia, you will find there is a movement. If there is no movement, then there is no tropia on that eye. Then cover uncover test. So I didn't put that first one here, I missed it, I'm sorry. But so first is the cover test. You simply put the occluder in one eye and see the movement of the other eye. Finished. Then cover uncover means you cover one eye and then remove the cover, and you see the movement in the covered eye. So this is cover uncover test. So you cover the eye, and then when you uncover it, you see the movement in that eye. because that is important also to know the secondary deviations, because if the uncovered eye has moved little bit, and when you remove the cover from the covered eye, you will see the movement. If it is more, then it is a secondary deviation which is more than the primary. So this one had a primary deviation, the other one had a secondary deviation. So it gives you an idea that there is some problem in incompetence of the movements. Then you have an alternate cover uncover test. Alternate cover uncover test, we can call it. Now you cover one eye and leave it for about 8 to 10 seconds. Leave the cover for 8 to 10 seconds, that is important. And then you cover the other eye. In doing this, you break the fusion. Our idea is to break the fusion, break the binocularity of the eyes. So you break the fusion. Once you break the fusion, latent strabismus, what we call as phorias, comes into existence. So then, I'll tell you a video if I say, normally the patient will not come. Now why this? And we have another one, is simultaneous cover prism. Now if you want to measure, if you want to see the exact movement, you put a prism and put the cover all simultaneously. This is to see the tropia and foria all together, both. And all these tests have to be done for distance and near, because there could be a disparity in distance and near. In myopic patients, for example, in hypermetric patients also, the distance may be different, the near may be different. Exotropic patients also, it may be different, because you might have a divergence excess, so you might have a more divergence in, actually the term divergence excess is now we are not using it. We have a basic strabismus, the tonic strabismus, and the abnormal ACA ratio that we see for exotropia also. But the books have, old books have still, so I mean you must know, myopic patients have, they have more for exotropia for distance, less for near. So you have to just see what it is. Now why this foria is important? Why to exclude or to know foria is important? See, this is important because there are a lot of, I have done I did 3-4 theses on this on my residents on the basically on the symptoms of ocular asthenopia. You see, the patient will keep on coming to you and keep on going to other places, and they would say that they're having headaches, they're having, red eyes after they work for some time, because the computers are now there. So if they're working on computers, they would have started headache after some time. Then they say, I get blurring after some time if I work for the... So there are a lot of asthenopic symptoms, ocular asthenopic symptoms. When you see the patient is orthotropic. You see the vision, it is 6/6. 30 to 35% of patients coming to the OPD, you see, because 50% are refractive errors, you must know that. And 3 years before, I have written a book on, by JP Brothers, it is there, it is here also in the JP Brothers stall, the management of refractive errors and prescription of spectacles. This is a book, it's a small book of 300 pages, but there I have shown that because most of the hospitals, they say, vision 6/6, no tropia, kuch nahi aapke theek hai, you go to neurology. 35% of patients presenting with these ocular asthenopic symptoms had phorias or had astigmatism. So 35% of the patient is a large number, is a very large number. You just leave them and they would have those symptoms. So when you test this, the alternate cover test, you get phorias. So if you have a phoria more than 8 to 10 PD, a phoria of more than 8 to 10 PD is symptomatic. So after some time you have the convergence is more, the medial rectus is overacting to have the fusion, the motor fusion is there, and because of that you get an ocular astigmatism and astigmatism, hypermetropic, myopic, both astigmatisms. So you must differentiate this. Otherwise, you will leave a large chunk of patients which have those symptoms, and they keep on wandering from pillar to post, and you would find that they are not curing. They went to ENT because they have 3-4 theses on this, on different headaches and then other symptoms like that. So the idea of instruction courses is that you must know the basics of all these things. Then we talked about this already. Now I'll tell you now I'll show you a video. See, just observe this boy. I have told him to look distance, far. And far means, see that the patient has a 6-meter distance, say outside the, now see, this is a simple cover test. You cover one eye and you see the movement of the other eye. And now I uncover and see the movement of the other eye. But there was no movement in that eye. I'll show you again, see, because this is important. So, thodi der, if you leave the patient for some time, say a few minutes, and if there is an actual tropia, exotropia, you will see the drift. Now see the left eye drift. Now I cover, this moves in. I cover, this moves in. So we had a left. Now when I cover the other eye, there is no movement of the right eye. Simple cover test, no movement. Now cover, uncover will show the movement. Now the important of this is that this shows that the patient has a unilateral exotropia. It is unilateral uniocular exotropia. And now the alternate cover test, you have to differentiate between the tropia. And why even if the patient has a tropia, you must do an alternate cover test. Must do it. Don't leave it there. If you have you must do an alternate cover test, because sometimes you see, because we operate on the total strabismus. We don't leave the foria. So if you have a 20 PD of tropia, and when you do our alternate cover and cover test, you will find that there is the strabismus goes to 40 PD, because the 20 PD is the amount of foria. So you correct 40 PD, because otherwise you leave him with 20 PD foria, the patient will have symptoms. He is not corrected. I mean, he is not treated correctly. So even in spite of having a tropia, you must do a proper alternate cover test to elicit the foria also. So that then we get the total strabismus. Foria plus tropia, and you operate on the total strabismus. That is the basic thing what you must know. Now see this lady. She is not showing any movement in both eyes. Of cover test also and cover uncover test also, she is not showing movement of any of the eyes. And don't do more than 3 or 4 times, otherwise the fusion will break. Now I am doing the alternate cover uncover test. Now see. See. See, do you see a subtle movement from exo to inwards? You have to keep it for 8 to 10 seconds. See, the movement is increasing now. The more you obstruct the fusion, the longer you put the cover on the eye, the more the fusion breaks. So you should always keep it for at least 8 to 10 seconds, at least. So this lady had, there are numerable examples, numerous examples. I'm just giving you one example, just because to show you. So this patient had headaches. She only came for headaches, saying कि she's around 35. And she says कि मैं जब काम करती हूँ मेरी headache थोड़ी देर बाद ही मेरे को headache होने लगता है. I read for some time, I start getting headaches. And she had no other symptoms. So now this foria, And she had hypermetropia. You see, hypermetropia again is a congenital problem when it goes. It is always congenital, remember, except if it has due to some disease or something that is different, otherwise of cataract. But you know, these hypermetropias which are from infancy, they don't have like 2, 3, 4, they don't have symptoms. Okay, when they cross 30, 35 near, then they start complaining. And they don't complain of near vision defect also, they only complain of headaches. Because that's why I got the thesis done on this, 3 theses, and we explored on these aspects, and you see, it was, it opened the eyes of the resident. They said ki sir, hamare, because some had did their MBBS from other places, on the other places. They said, sir, we never knew about this. We never thought, we only used to do 6-6, only 6-6. Fine. Distant, near, 6-6, J1, ठीक है, पेशेंट इज फाइन, आप दूसरी जगह दिखाओ, आपको न्यूरोलॉजी में दिखाओ, हेडेक की प्रॉब्लम है, बीपी टेस्ट कराओ, ऑल दीज थिंग्स. 35, almost 35% of patients with ocular asthenopia or these sort of symptoms have phorias. And as I keep on increasing blocking the fusion more the is releasing. It's almost about 20 PD of phoria. Now, I gave her specs because she was hypermetropic. I gave her correct. And you should always correct for distance, full as agar +2 ka hai, at this age give +2. Just see now, because I already know about these things, so I am directly doing cover and cover. But see, the movement. See, it is still there. Though I have corrected hypermetropia, she has been given plus lenses, whatever the refractive error was, but she still has phoria. So this is, and she might be having, now she must be having intermittent exotropia. Gradually she would have, so this is a non-refractive element of phoria. So it is a muscular problem, right? So muscular problem. So, and if I don't treat her, she would gradually go into a constant exotropia, maybe alternating or maybe this thing. Now why, so how do I treat this lady? How do I treat this lady? बताइए आप में से कोई अगर, how do I treat? Now I give her a specs, hypermetropy correction, the phorias are still there, जितना 20 PD है, 20 PD अभी भी है. So what do I do? Yes, please. Number 1, we give her convergence exercises. No, she says she's whenever waking का सवाल नहीं है. She says she has headaches when she does the near work. She gets headache when she does the near work. Whatever, paper पढ़ने के बाद आधे घंटे से ज़्यादा paper नहीं पढ़ सकती हूँ मैं. That is what her complaint was. See, now because I have hundreds of patients like this, but I'm just telling you one example जिसको मैं note लिख के लाया हूँ कि इसके complaint क्या थी. Because I also forget. She might have come to me a few years back. I don't remember. But patient which I have to show you people, I write it. She had complaint for near work. So. She binocular means reading glasses also. मतलब bifocals you mean. Bifocal का एक तो, but she does not have an abnormal AC ratio. कोई उसमें there is no difference between distance and near. जब distance and near का difference है, bifocals will not work. You see. So number 1 is convergence exercises. Fine. Number 2, because these patients now at the age of 35, 38, they do not improve on exercises. अभी खैर ये तो 20 PD है, हो भी सकता है. The other thing is you can give her prism to elevate her symptoms. That's all. But the phoria may manifest. Because once you have given the prism, the phorias may manifest. So that you have to tell the patient कि आपको थोड़ा सा दूर कोई बोलेगा कि आप you have a misalignment, but don't get bothered by it, but wherever. So these two also things. And if the patient has problems even then you should operate. Okay. Now this patient. भाई आपका ये cursor. Now see, this is a clear-cut exotropia. Now, this is, you can see it for distance. She has an exotropia. Did you look like exotropia? It looked like an exotropia, but there's no movement of the other eye. On the cover test, there's no movement of the other eye. But then see, when I cover the left eye also, there is no movement. But when I do this alternate cover and uncover test, now you see.
There was some movement when you uncovered the right eye.
No, because I had covered for a longer time. Oh, fusion break ho gaya. The fusion broke. But it should not, you should only keep it for not more than 1 to 2 seconds. आप कवर किया, हटा लो. कवर किया, हटा लो. आप कवर किया, दूसरी आंख देखो immediately. कवर किया दूसरी है. But don't put it for more than 1 to 2 seconds. Remember that is very important. अगर आपने थोड़ी देर ज़्यादा रख लिया, fusion break हो जाएगा और आपको फोरिया दिख जाएगा. खैर, that is good. You want to see the foria also. But then your testing would differ. Now this is another boy. I already given him specs. See, I am not keeping for more than 1 to 2 seconds. Cover test, no movement of the other eye. Cover test, no movement of the other eye also. Both eyes, no movement on cover test. Then I do the alternate cover test now. Yes, see the movement. Almost 30 PD of movement is there. I didn't show the previous. The patient had a large, this boy had a large exophoria. I gave him minus lenses. He's a myopic patient. And I thought that maybe because of the convergence, because the myopic patients do not converge properly, because they don't need convergence, so accommodation, so that convergence accommodation stimulus is not there. See, so इसलिए इनके भी कई बार blurring तो थोड़ी देर बाद there would be a blurring because the -3 he is not converging. He can see, but then gradually the vision becomes monoocular because there is no convergence, so binocularity नहीं रहती, तो near में distance में disparity होने लगती. So you should always correct a full correction. किसी ज़माने में जब when I was doing MBBS, my teacher used to say कि myopic lenses को myopia में ज़रूरत नहीं बच्चों को करने के लिए. You don't need it. Very happy, ताली बजाते थे कि parents भी खुश कि चश्मे की ज़रूरत नहीं इसको, है ना? See, those were lopsided ideas we had before, but now we know that what has to be done. This is another patient. This is better way show you some examples. Now see this patient. See, I just put the cover for a second, and you see when the patient had come once sitting, she had no tropia. Immediately I put she elicited a large exotropia. Now see, the right eye is not fixing. When you do the cover and uncover test, you also have to see the movement of the other eye. Because cover, uncover test, you see the movement of the other eye. When you uncover, you see the movement of the other eye. You should take fixation again. But the patient was not taking fixation. There is a deep amblyopia of this patient had a deep amblyopia. Almost, I would say 15, 16 years of age, she had a deep amblyopia. So these are different. Every patient would be different to you. Every patient would be different to you. So you must master these basic skills. You must master these basic. आपको अगर ये basic skills if you have mastered, half of the work is already done. Because there have been if people who have attended SPOSI, I had demonstrated a paper, the errors, the post-operative errors of surgery, and one of the biggest error when you do after surgery, when you have over or under correction, is because you did not measure and you did not know the exact type of strabismus. You had miscalculated the strabismus, you had not properly calculated the strabismus, not measured properly, and then you get these problems. So why I kept this basic last year also there. Last year it was one day before, so there was a lot of people, and this anyway. This is last day. I'm very sorry. You know, I also feel bad that this is important. Patient should care. आप लोग SPOSI में भी we can have covered this in SPOSI. Will attend. We have a midterm SPOSI in Hubli. Then we have an annual SPOSI, which is again going to be an international conference at Chennai. It is organized. Will be organized by Shankar Nethralaya in December. First week of December, so you can block your dates for Strabismus and pediatric ophthalmology. We have session there. Now, simultaneous cover and cover. Now, why this is important? Now, I have already measured. The other speaker has. Now we go to paralytic and okay, we have still a lot of time. Now paralytic and restrictive, I wanted to show you that, sorry, in this. इधर की मत जलाओ आप, हाँ बस बंद कर दीजिए, बस उधर की चलने दीजिए, इधर की मत जलाइए. तो जला तो देख लो, फिर आप देख लो. हाँ now see, this simultaneous prism cover test is meant to know the whole total amount of phoria plus tropia. Phoria plus tropia. So you get the exact amount of, exact measurement of the total amount of strabismus. That is the idea of this. Now after having seen this, we see the other aspect of strabismus, which is the paralytic or restrictive. Now restriction of movement in a field of action of the affected muscle, that is what we call as a restrictive or paralytic strabismus. Deviation of eye in the direction of antagonistic muscle. You see, secondary deviation more than the primary deviation. These are the three basic concepts when you see for the paralytic or restrictive strabismus. Now see this patient. भाई ये आपका what doesn't it, कर्सर क्यों नहीं मूव होता इसमें? Now just carefully see this patient. Orthotropic, no movement on cover test, no movement of cover and cover test also. Same eye, other eye, no movement. See, now I keep it for a longer time. Now you see the movement has started. Now I do the alternate cover and cover test. See, the right eye from inwards has moved, is moving outwards. See. See. Now see. Right lateral rectus paresis. The patient came for diplopia. The patient came for diplopia. Now see, the movement is there, now there is no movement. See, the right eye, the movement is restricted, the right lateral rectus palsy. Now in such patients, you have to differentiate whether the patient had a long-standing exotropia and there has been restriction of the medial rectus. That in an adult patient you can very easily do an FTD, that is a forced duction test, you can very easily do. There's no problem. I'll tell you, talk of that later on. And now this patient, just another example. अरे आप क्या कर रहे हो भाई? जला दीजिए आंखें लाइट आपको चीज से. Large angle esotropia, right eye. When I cover the left eye, the patient should take fixation of the right eye. See. This is okay, movement. This is okay. Down movement, the patient is. Slight overaction of the superior oblique, it doesn't matter. But what I want to show you is see, there's a large angle right unilateral esotropia. See, the eyes is not fixing. The right eye is not fixing. Right rectus palsy. See, there's no movement, zero. There's no movement of the right eye. Long standing right lateral rectus palsy. Now, after having ascertained the type of esotropia, phoria, and the amount of esotropia, or tropia, whatever you have, then you test for ocular movements. Now, ocular movements you test for ductions, versions, to be examined in 9 cardinal gaze of movement what we have. See, one thing you should remember, that we see the movement of the eyes in all 9 cardinal gazes, right? 3 up, 3 middle, 3 down, right? But when you test for the muscle action or under action, you test for only 6. You don't do up and down, not straight elevation, not depression, because in straight up and straight down, you are not testing the individual muscle. What we want to test the individual muscle. So when only you have 6 movements, 1, 2, 3, 1, 2, 3. Right upper, right lateral, right lower, left upper, left lower, left lateral, and left. Because by this you test the action of all 6 muscles. So when you test for overactions and underactions, when you to gauge by +1, +2, +3, whatever it is, or minus in underactions, you must always do 6. And there's a chart. I'm sorry, I didn't, because I missed it. There's a chart. There's a straight line and then 2 vertical lines. And when you chart the action of the muscle, you chart on that. Suppose there is right superior overaction, +2. Then in that you make a horizontal line, 2 vertical. Right up में आप लिखेंगे +2. Under action you write -2. There, this is how a chart you have to make when you, after testing the ocular muscles. Binocular movements, you test for how the eyes move together. And there are 2 important movements which you test when you do a binocular testing: saccadic movements and pursuit movements. And of course, if you have a paralytic or restrictive area, then you can see whether the eyes, how the 2 eyes are moving in different directions. They are not, moving in this, Now, having ascertained this, you see the movements, you have seen the saccadic movements all right, because that is important, because there are a lot of problems where there is a problem in saccadic movement and smooth pursuit. The vision is, there are a lot of conditions where you have where deficiency of smooth pursuit movements. You must always see this. Anyway, once you have done that, then you move to the history taking. Actually, I always do the history taking later, because what happens if you ask too many questions, keep on asking children, because mostly they are children, then parents and children, the child loses the interest in you. This is one of the very basic things which you have shown. When I did my fellowship at Johns Hopkins, USA, the world's leading university, they always said, first see the child. As soon as it starts coming inside your room, look at the child. You will get a lot of information as the child is coming to your room and he is sitting there. Always put it's a small child, always put the child in the lap of the mother. That is the child will be comfortable, it will be cooperative. So when if you start asking too many questions, the child will also become irritable, the parents will also become, the non-cooperative, and the child will lose interest. फिर आपकी जो examination है, वो suffer कर जाएगी. So as a matter of fact, I start testing before. And once I have seen that what type of tropia it is, or phoria, or what the problem, whatever it is, then I start asking questions. Because then I'm not then the child is not the concern. फिर मैं parents से पूछूंगा सारी चीजें. ये थोड़ा सा, these are the tips, the tricks of the trade, you know, where you. So you first examine the child. That is what I have been doing for last 20-25 years, you know, and I have no problem. 20 years. So you must then ask the patient, the parent, because the child may be 3 years, he will not be able to answer. Age of the onset, whether deviation is constant or intermittent, deviation present for near distance or both. We have seen those videos before, see, it was present sometime back. Does degree of deviation alter during the day? You see, because the patient is tired, then there would be a deviation. In the evening, there is more deviation, because then you have to also think of some other myasthenia gravis and other type of problems, you know. Then old photographs, you must always get old photographs of the patient. Is a rule. I'd see the patient in the first visit, then tell them to bring the photograph in the next visit. I want to see whether the misalignment is congenital or it is acquired. Because if it is congenital or infantile, you know, because before 6 months of age, then I have to explain to the patient about the prognosis of the treatment and the prognosis of the vision. I have to tell them. Otherwise, most of the patient, half of the patient, आपसे क्या पूछेंगे मालूम है? They come, if you tell them that this has to be operated now, you see, there's no other treatment, it has to be operated, the eyes have to be made straight. Then they will ask, सब इसकी नज़र तो आ जाएगी ना? Very, very important. They will definitely ask you कि साहब इसकी नज़र, because the vision is low, amblyopia है, ये है, सब चीज़ें हैं, you know, refractive errors इतने सारे हैं, तो they would ask you, साहब नज़र तो आ जाएगी ना? That is the point you have to take. You see, we are not operating for vision. We are not operating for vision. So this is very important. You should get the old photographs so that you should know what is the type of that. Birth history. Always take family history of strabismus, goes in families, we already know. Is it associated with headaches? If it associates with headaches, I do a refractive. There is a age match. We had in the 2 days before another instruction, so we had people, they were discussing what type of cycloplegia to be used. In my book which I have written, I have used that atropine up to 2 years, 5 years, homatropine, 12 years, cyclopentolate, and about that up to 18 years. Tropicamide. So there were discussion, you know, you should use atropine or homatropine even up to 5 years of age. That's okay. It's different. If you see that is in hypermetropia, then you must always use atropine. But I always refract again after 3 months. You would find a change in refraction. Any medical history of illness, is the patient under medical treatment? You must know. There have been a lot of patients who have been treated for epilepsy. They are under treatment for epilepsy. And those anti-epileptic drugs, they diminish the movement of muscles. They affect the attentiveness of the patient. You might be testing and the patient may not be attentive. You might get a false results. So you must always ask. I don't know of how many you ask about the patient's illness and medications he is taking. Okay? This thing. Measurements, precise measurement steps is the hallmark code. Potential errors and complications can be reduced in patients by recognizing of certain optical issues. Therefore, certain basic optical issues should be kept in mind. Now, I'll tell you that this is important. Angle kappa and angle lambda, it comes into the picture. Angle kappa especially, it's a normal angle between the visual axis and the anatomical axis. So, a positive, if you have a small exotropia, up to 5 to 8 exotropia, most of the patient have it. That is a positive angle kappa, difference between line of axis and the anatomical axis. You must take into account, because then you got a false result. Now, anyway, we'll leave that. Now, start testing now. Now, testing of strabismus. You have Hirschberg and Krinsky test. Hirschberg test measures the deviation in degrees and is determined by observing the position of reflection, not reflex. It is not a reflex. It is the first Purkinje image from the surface of the cornea. Okay? It is the first Purkinje image, and in the front of the surface of the cornea, which acts as a convex mirror. So that's why what you are seeing is the reflection of a torch pen light. It is not a reflex. All the books have written corneal reflex, reflex, reflex. Jitendra, do you agree with me? So it is not a reflex. It is a reflection. It is a first Purkinje image. So it is naturally not a reflex. Okay, the position of corneal reflection with respect to the center of the pupil measures the amount of deviation. Now, it has a lot of fallacies. The pupil may be eccentric, the cornea may be this thing, and the pupil may be, you know, the distance when you are, if you are measuring from too near, the pupil would constrict, you know, because of the near reflex, you'll get a wrong result. Agar aap thoda dur jayenge, to, you know, all those fallacies are there. So we don't use Hirschsprung. Please, as a strabismologist, as a pediatric ophthalmologist, don't use Hirschsprung for measurement of strabismus. This is a big no. So 1 millimeter of displacement gives rise to about 7.5 degree of displacement. That's how you see. You see, one millimeter of displacement from the center of the pupil or center of the cornea is equal to 7 to 7.5 degrees. Okay, so 2 millimeter, 15 degrees. तो आप जब उसको नापते हैं कि pupil, see again you see 15 degrees, you say because it is at the corner of the pupil, at the margin of the pupil. So again if the pupil has a different तो आपको वो गलत हो जाएगा फिर. So we don't use that for this is I've only given a now Krinsky test, it works on the same principle as the Herbert test, except the prisms are used for seeing the corneal reflection on the cornea. But both these tests have inherent fallacies and incorrect for measurement. Even Krinsky's, they are therefore not used for refraction. What we now use is a standard measurement is that we use a modified Krinsky. We give a target to the patient. We give a target, distant target. आप best है अगर आपके इसमें if you have a projector, you have Allen's charts and other charts and, you know, Lee's symbols, everything. Whatever you can show the patient, a small child or even a bigger child, आप उसको कोई symbol दिखाइएगा. अगर पढ़ सकता है तो E दिखा दीजिए सबसे ऊपर का. So that is a distant target. Let him focus. You have to have a target to focus. Okay. So वो दिखाइए, measure, and then you see the deflection. You neutralize that deflection by prisms. You don't see the corneal reflection on the cornea. You see the movement and you neutralize the movement by prisms. So that is how you get it. You have glass prism, you have plasma prism. The measurement is depicted in prism diopters. You know, one prism diopter is movement of the image by 1 centimeter at 1 meter distance. Is it correct? Or understand that? So that is one prism diopter. Now, the following requisite should be kept in mind when measuring strabismus, because I told you this is a prerequisite for your good outcome of treatment. Okay? Eye movement capability. If the patient is not able to fix, then what will you do? I showed you that video before. The patient was not fixing. Paralytic है, restrictive है, amblyopia है, patient fix ही नहीं कर रहा है. आप कैसे measure करोगे फिर? Because you neutralize the movement. You say, what you are neutralizing? You are neutralizing the movement. So then you have to see, you have to see the reflection of your pentlight on the center. जब आपको, you keep on increasing the prism, when the reflection comes in the center of the cornea, that is your end point. So that is how you see, but that is very rare, you know. Foveal fixation, attention is very important, cooperation. If the patient is unable to maintain fixation at a specified target, the result of cover test may not be valid and your examination may not be valid. Now, position of prisms, very, very important. The amount of deviation produced or measured by a frame depends upon the position of the prism in front of the eyes. Remember this is very important. So we have 3 positions where we put the prism for measurement. The Prentice position, and when you do a Prentice position, you use glass prism. But most of us we are not using glass prism. We are using plastic prism, acrylic, which is an acrylic. Then minimum deviation position and frontal position, which is mostly which I am doing. Now these are the 3 positions. See, the Prentice position is you put the prism in the line of the direction of the strabismus. It's a line of the alignment. You do glass prism, but this has fallacies, so we don't use it. Then we use a maximum deviation prism, which again you use a plastic prism. There's a difference between plastic and glass. The glass has a refractive error, so it deviates more the rays. So you must remember that आपको उससे subtraction करना है. So don't go into that rigmarole. Use plastic prism. We have a standard there. Then the frontal position prism, which is universally being done now, which I am also doing and most of you also must be doing. You put the prism in frontal position of the eye. We are not concerned about the deviation. We put the prism flush frontal with the position of the eye. or position of the frontal plane, that is what known as the frontal plane of the eye. We put the prism there and you keep on reducing or increasing space as is required. Now stacking of prisms, that's very important. This is a common mistake. Stacking or joining of prisms together, especially one of high power, results in large errors. For example, देखिए आप, you can copy it down or you can take a photo if you need. See, for example, a 5 PD prism attached to a 40 prism. अब आपने 40 किया और देखा कि अभी भी 60-70 का है, मान लीजिए exotropia और esotropia. You are not able to naturally neutralize by 40, so you put more prism on that. Okay, attached to a 40 prism produces 58 prism diopters of result. आपको 45 प्रिज्म आपने एक के ऊपर एक अगर उसको स्टैक किया तो आपको रिजल्ट 58 का मिलेगा. And a 10 PD prism to a 40 prism attached to a 40 PD prism produces more than 100 PD of result. आपको जो आप मेजर करोगे, you will measure it as 100 prism diopters और आप 100 prism diopters का करेक्शन कर दोगे. Look at the fallacy. So reason, even if the first prism is in desired position, frontal position, the second prism is not in the frontal position. It is an oblique position. Because आप उसके surface पे दूसरी surface रख रहे हो, वो position different है. वो Prentice position पे चली गई है. And the result is augmented. The more you stack it, the more augmentation of the result. So please do not do that. Please, for God's sake, do not do that. If you have a large strabismus, then you divide the prism between the two eyes. Okay? So this is important. Therefore, in measuring, but horizontal and vertical can be stacked. As the interface does not interfere significantly with the final power. That is very ridiculous. But these are all physics, optical physics. We are not concerned. इसमें दिमाग लगाने की ज़रूरत नहीं है अपन को. Okay? So, some amount of error results. ये कहते हैं उसको भी आप, the higher you grade, because you see vertical strabismus अपन को इतना ज़्यादा 40 से ज़्यादा आता नहीं है. A single prism will do it. Okay? That also you can split in two eyes. Yes, you can split in two eyes. So measure deviation of each eyes and you can do it. Now, so this is how you measuring, simple measurement. And you see, I am not doing a cover uncover. I am doing an alternate because you always measure with the cover uncover test to have the full amount of strabismus. Okay? I will stop here because we started late, 15 minutes, because there was no audience. So, okay, I stop here and we have other speaker he would speak on. Then for last मैं आपको मैं एक बार और बता दूँगा. Thank you very much. Okay? Any questions? Yeah.